This is Call the Psychiatrist, the show where psychiatrists answer your questions. I'm Dr. David Handley.
And I'm Dr. Abby Snavely.
On today's episode, we have two listeners' questions to answer. Why is bipolar overdiagnosed? And why do you make such a big deal out of the therapeutic relationship?
Say you like me, you better count the ways.
Before we get started, just a quick stop for the disclaimer. This is a podcast. Just because you're listening to this podcast does not mean we have a doctor-patient relationship. Our intention is to educate and entertain you. Nothing we say is intended or recommended as a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your own physician or other qualified healthcare professional regarding any medical questions or conditions. All right, let's see. Our first question comes from Shelby.
Can you talk about society's misconceptions of bipolar disorder, their origins, and why you think the disorder continues to be so overdiagnosed and treated?
So I think this is a great question, and I think that we can hit the highlights of many, many different things that contribute to the overdiagnosis of bipolar. But I want to acknowledge that there are plenty of clinicians and researchers who think that we're probably underdiagnosing bipolar and that the criteria should be even broader, or that we just need to change our conceptualization about mood disorders completely. So I happen to agree with Shelby that there is an increasing number of people misdiagnosed. I've seen this over my own career, although the trend, and we'll get into the numbers in a second, probably starts back in the 90s. But what about you, Abby? Do you think this is an accurate assumption that Shelby's made in the question?
Well, I mean, she does say that the disorder tends to be overdiagnosed, and I think that's true sometimes. I think it is also sometimes missed, and I'm sure you'll get to that. I would definitely agree that there is plenty of misdiagnosis going on. And, if I had to pick one side, I would say more over than under. But I think there is a misunderstanding, definitely in the public, but even within our profession or related mental health professions, about what constitutes bipolar disorder. So, yeah, I mean, I think that probably I've had more time undiagnosing people coming in with the assumption that they have bipolar than the other way around. But I've definitely been humbled on both sides.
Well, I do want to start by discussing the numbers so that we can at least be clear about the diagnosis we're talking about. I think I can at least show in the numbers that there's an increase in the diagnosis. And then whether you'd call that overdiagnosis or misdiagnosis, I guess may be up for interpretation. But one point I wanted to make is that we all know that the diagnosis of an illness sometimes will increase if the definition of the illness changes. And so an example that I think of from a few years ago was what we consider to be hypertension. So it used to be if your blood pressure was 140/90, you had hypertension, and they changed the criteria so that anybody with 130/80 now had high blood pressure. And so just overnight, you've now picked up a lot more diagnoses than you would have. And so I think sometimes this is a reasonable assumption. But with bipolar, at least in the severe form of bipolar, this doesn't appear to be the case. We didn't really have an agreed upon definition of bipolar until about 1980, when that term was included in the DSM, the Diagnostic and Statistical Manual, the book where all the psychiatric diagnoses are recorded. Before then, manic depression was the more frequently used term, which is actually a lot more descriptive, because to make a diagnosis of bipolar, a person has to have had mania. So no mania, no bipolar. There's a less severe form of the illness where the symptoms of mania are less severe and the state doesn't last as long, which we call bipolar 2, and we say those patients are experiencing hypomania. Okay, so since 1980, the criteria for bipolar 1 hasn't really changed. The criteria for bipolar 2 hasn't really changed much since it came out in 1987. And the prevalence of those diagnoses haven't really gone up, although bipolar 2 has started to creep up in more recent years. So what actually started going up was the prevalence of something called unspecified bipolar. It's this third catch-all category. By the late 90s, early aughts, people were using terms like bipolar spectrum or subsyndromal bipolar, soft bipolar. And there were researchers with published articles that were suggesting that we have bipolar type 1.5, 2.5, 3, and 4. And so it's hard to actually track the prevalence of this third amorphous category because there's no validated criteria to even make the diagnosis. So the lifetime prevalence for this bipolar spectrum is now ranging anywhere from 2.4% to 4.7%. In other words, almost 5 times more prevalent than bipolar 1. So what happened? Well, I think the answer is pretty complex, and I'm going to try to weave several big ideas together. I want to say, though, from a historical perspective, these trends are really recent for an illness that has probably been around for millennia. As far as humans have been around, there's probably been some form of this illness, but yet, we're talking about just in the last few decades, a big change in how we're trying to understand this. And so I want to be complete, but I'm just going to hit the highlights because I know, Abby, you're going to give me a hard time if I give all the history I want to give.
We just don't have time for it.
All right. Well, I'm at least going to touch base briefly with Kreplin.
Please.
Okay. He gets credit for the term manic depressive insanity about 1900. But what was important is that he actually distinguished that there were people who had mood-related psychosis, and then there was everybody else with psychosis. And one of the observations was that the people with mood-driven psychosis eventually would get better and leave the asylum, until they relapsed again. So it was just this one categorization, but it wasn't really until the 60s that researchers even distinguished a unipolar versus a bipolar disorder. And then that term bipolar becomes more widely used from that point on. And so the criteria, in other words, like how we might diagnose it, was worked on through the 70s. Lithium gets approved during that time, which led to a greater interest in making an accurate diagnosis. And so finally, we get some validation data and the diagnostic criteria in 1980, which is what I had mentioned earlier. We talked back in episode 3 how schizophrenia used to be overdiagnosed in the mid-20th century, especially in the United States. Well, one reason schizophrenia stopped being so overdiagnosed was because bipolar started being diagnosed more regularly. There was this interesting study in the late 70s showing that U.S. psychiatrists identified schizophrenia over bipolar in a ratio of up to 12 to 1 compared to their Western European counterparts, where it was closer to 1 to 1.
Wow.
All right, well, let's get back to the question of why the trend happened, like what happened with this third category and why the prevalence increased. And I think
Are we going to start talking about money?
Yeah, exactly. I think always follow the money first.
Show me the money. Yeah,
that's right.
Mm-hmm.
And so that's going to be, we're going to start looking at pharmaceutical industry and then the impact that managed care had on the way people are treated. So Prozac hits the market in the late 80s, and it's hard to overstate how important or the magnitude that Prozac had in this country and everywhere. That class of drugs would become $1 billion industry. And Prozac and its cousins revolutionized the treatment of depression, particularly because the risks of treatment were lower. So the older drugs were harder to tolerate, they were deadly in overdose, there were diet restrictions, and now suddenly it was easier. And this had a huge impact on primary care general practitioners who started diagnosing depression and prescribing medications. It was quick, it was easy, patients were demanding it, and the doctors were getting paid for it. So with the rise of managed care and then decreased reimbursement, there was this pressure to increase the number of diagnosis codes during a visit to try to capture some of that lost revenue.
Yeah. And Dave, are you talking about outpatient visits here, or are you also thinking about inpatient?
Yeah, I'm really talking about outpatient because I think that's where the influence from the drug companies was so high in terms of trying to focus people on recognizing depression, which again on the positive side, that's a good societal thing. Recognize a problem, alleviate suffering, but at the same time, it's being pushed so heavily, and there's a financial incentive. And I think the ideal thing that we would like to have happened maybe wasn't always happening. So as antidepressants are being prescribed more, when you do that, you then have to ask a patient if they have a history of mania, because it's possible that for some people, if they have bipolar, an antidepressant can make them worse. Well, the more patients you start screening, the more likely you're going to have a false positive for mania, or at least symptoms of mania, but no clear diagnosis of bipolar. So what do you do with them? That's, I think, where that third category comes up. And then the other thing I want to bring about with managed care is that those doctor's appointment times are getting shorter and shorter. There's pressure for efficiency, for throughput, and there's really no time to sort out this information they're getting on these questionnaires. So a patient comes in, they tick off a couple of boxes on a mood questionnaire, and now they have something that's not quite bipolar, but you don't have time to sort it out. So we'll say it's somewhere in the bipolar family, and we can medicate, bill, and move on. So this system doesn't reward
And
thoroughness.
it doesn't. Well, and even in that setup that you're describing, it also, which I think is completely backwards, but it makes it seem like it's safer to diagnose someone with bipolar rather than unipolar depression. Because if you diagnose them with unipolar and you give them an SSRI, they could become manic. But I think in that setup, it's like, well, it's really bad to miss bipolar. So to your argument, I think you widen the net and over emphasize the danger of misdiagnosing someone as unipolar depression.
And I would say discounting the danger of the other diagnosis in terms of the toxicity
Correct.
of the medications and without really any conversation about how to mitigate the risk if you're going to give an antidepressant to somebody with an unclear history. Perhaps closer follow-up, additional outreach. I mean, there's ways to make it safer, but again, those aren't very clear in a system that values productivity over accuracy.
I even saw a study, and this had to do a little bit more with conversion or factitious disorders, but they asked primary care docs and psychiatrists to define what they thought close follow-up was. And the psychiatrists were saying twice a week or minimum once a week. And I think the primary care doctors were like maximum surveillance once every 3 months. Which again, I think just speaks to a different frame, but mostly how much time people have. They were like, no, that would be like a really, really intense schedule for keeping an eye on somebody.
Yeah, I've worked in systems where after an initial visit, it's follow-up 6 to 9 months, or at least in 12 months.
In psychiatry?
Yeah. And you have to think, well, if they didn't need to come back for a year, did they need to come at all? I mean, maybe that's the issue. I don't know, but it's always been very surprising to me. But to get us back to the 90s for a second, or no, actually not even to get back to the 90s.
I mean, the 90s are back fashion-wise. We should just stay here a while. I'm sorry to keep trying to modernize you. It might be the same.
But I just want to point out that what would be an ideal thing to do would be more time to get a history, more time to get collateral information from family or friends, getting old records and reviewing those. I mean, all of that is time intensive, and all of that is something that's not done enough. And then the other thing, which I think is this to me, I think is one of the biggest points and one of the things we won't explore much, but I think with the rise of the antidepressants, we're now finally shifting psychiatry into this medical model, which is you have a symptom and here's a pill for it. And I think that has a lot to do with this story. So let me bring in another medication to kind of make my point. Okay, Zyprexa. So this is a medication we call a second generation antipsychotic. It was approved in 1996. By 2000, it would be approved for use in bipolar mania, but it didn't really matter because in 1997, the FDA relaxed restrictions on direct-to-consumer advertising. And so now you get patients who are way more open to treating their mood problems with even more potent drugs. And you've seen these ads, ask your doctor about symptoms of depression or symptoms of bipolar. Again, that medical model of, what's going on with you today, and there might be a pill for it. And then drug companies and then doctors start using the term mood stabilizer, even though that language isn't anywhere in the FDA for any drug. But, that word sounds like something that we could all use sometimes, right? Just to smooth out my mood. I was a little moody today, moody yesterday. I want to stabilize
who doesn't want to be
things.
more stable?
Yeah, and it's so gentle too. I mean, to think about what stabilizers do, I don't know.
It's very insidious, and even just the idea that we allow direct-to-consumer advertising, right? It's only the United States and New Zealand, and psychiatric drugs are such a prime moneymaker in this regard because everybody has at least a couple of the symptoms that they're asking people to check off, right? Do you ever feel down? Do you ever feel unstable, overly emotional? How's your sleep, right? I mean, ask your doctor. I was talking to my kid about this last night where we're watching Project Runway, and apparently there's a big run on psoriasis medications now, but man, there's a lot of ads. He was like, wow, Mom, this is a big problem. I'm like, it might be. I'm not sure.
Right. Or there's a new psoriasis medication. And so, yeah.
No, that's all it, of course, that's all it is. But it's like, but it's like, it's showing up in these ways. And I think people understandably aren't even aware of how abnormal and backwards this is.
Yeah. Well, we get to 2002, and there's a study looking at primary care offices where 30% of patients presenting with symptoms of anxiety or depression were actually diagnosed with bipolar spectrum disorders. And I've actually, and you asked me this earlier, but I've been focusing more on the outpatient and even general practitioners, but it's not their fault by any means. Psychiatrists were doing it too. But what we have seen, and these aren't great studies, but that more of the patients in this category, this bipolar spectrum diagnosis, were actually being treated by their family doctor and not in other psychiatric, mental health clinics or hospital systems. Okay, so by 2008, the second generation of antipsychotics had become a top selling drug class in the United States, worth $14.6 billion. Now, these are indicated for schizophrenia and mania. You know that it wasn't 14 billion just treating those people. I mean, it just speaks to how many people were now exposed to these potent drugs with potentially horrendous side effects. And that if you're going to take it, you would really like to know.
And to be clear, that if it's mania, then it's bipolar 1, right? This isn't even bipolar 2 or the rest of the spectrum or the wastebasket, like unspecified category. That would just be if it's just approved for mania, then it's supposed to be bipolar 1, which I would say does not get overdiagnosed if people are actually looking at criteria, right? That is one that is pretty easy to demonstrate.
Yeah, and again, the lifetime prevalence hasn't changed much because it's pretty stable.
Correct.
Yeah. Right. So that same year, 2008, there was a study by Zimmerman who could confirm the diagnosis of bipolar in less than half of a sample of patients with a self-reported diagnosis of bipolar. And many of those overdiagnosed were felt to have an actual diagnosis of borderline personality disorder. And so I think that brings us up to now several points that we can talk about. Yeah. And one of those is about the overlap of symptoms with bipolar. So what are other things that this could be besides bipolar?
Oh, let's see. We've already mentioned unipolar depression, substance abuse disorder, borderline personality disorder, other personality disorders. I don't know, PMDD, which may make it on a later episode. Thyroid disorders. I guess that somebody should be screening for that, but we know they're not always. Yeah. Anything else I'm missing? Did I say PTSD? Did I say trauma? Did I say, any of that?
Yeah. And, there's a trend that when a diagnosis is uncertain, we tend to go for a mood diagnosis rather than a diagnosis around substance use, around personality disorders. Now, I would say that I think that has a lot to do with the fact that some of the people making the diagnosis either don't have the time or don't have or feel uncomfortable talking about what's actually going on. And I think there's also a pull that, well, if I just call it bipolar, now I have this whole pharmacopoeia of medications I can start giving you. And now we're back into the medical model. You come, I adjust your medications, you leave, and we don't really have to talk about the messy part of what's going on.
Right. I mean, and to that end, I think that bipolar, in a sense, is become very destigmatized, which has both pros and cons. I mean, I would never actually root for stigmatization, but in terms of something that I think people sometimes could use as an excuse, people could use as an identity, helpfully or not. People could use the treatment of it as a way of just saying, well, my meds aren't right, rather than working on anything else. I think it makes short-term some things seem a little easier, maybe for the doctor and for the patient, but in the long term, I'm not sure it's doing anybody any favors, because if the diagnosis isn't right, the treatment won't be right.
Yeah, and I agree. What I see sometimes, I don't think this is necessarily conscious on the patient's part, but it's a way to surrender some agency. I mean, that the problems are external to them. And then I think that gets reinforced because then it might be a way to avoid consequences. And this is more pejorative, but it's not uncommon that I might hear somebody say, well, my bipolar flared up yesterday afternoon, which is why I acted like that. And the harder reality is that, well, no, you're not bipolar. You're just a very unpleasant person and you've been mean to your wife forever. I mean, that moment is not related to some outside force that you have no control over. And if you want to get better, we're going to have to talk about that and not just tinker with your medications and hope that you start treating people in your life better.
Well, and that everyone has mood swings, right? Everyone has emotions. People can express them differently. But having a flare for an afternoon categorically takes somebody out of that diagnosis, right? I mean, by definition, the mood episodes need to last days or weeks, not hours or minutes.
Well, unless you're in the other camp, and then you just say that, well, your standard needs to change. What you're using.
Ultra rapid cycling or something. Which, I mean, talk about a rare thing. Well, it's not my camp.
Yeah. I mean,
Okay, fine. Give me the argument. I want to hear it.
The argument for what?
I don't know. For the incorrect camp that says that anybody with mood dysregulation should be diagnosed with bipolar disorder. Is that what you're going to argue for?
No, the idea is so foreign to me. I'm not actually sure what the argument is, except to say that, well, anything aberrant we can pathologize. And I would still argue that in doing so, what you're really doing is just creating something that you can medicate. Mm-hmm. But I realize I'm headed down a cynical path, but
I say that is dark, bro. Yeah, And to be clear, though, I think by and large, everyone is trying to help their patients. No matter which discipline or which subspecialty of medicine. I don't think that very often are individual doctors or nurses trying to. Maybe they want to expedite things or make things easier on themselves, for a variety of reasons. But I don't think it is because of any desire to harm or pure greed. I just think there's like a lot of pressures. I mean, to keep your job at a lot of places, you have to get a certain number of patients or RVUs or billing dollars or whatever. To an extent, you have to play by the rules of the system. And I think the system is pretty messed up and evil, much more than the individual players in it. And I definitely don't want to demonize the patients or necessarily criticize them, especially if a doctor has presented this idea to them and promoted it as the truth. I mean, if someone says I'm suffering and comes to a doctor for help, to an extent, I'm not going to blame somebody if they believe what the doctor tells them.
I agree with you. There is one category of patients, though, where there is secondary gain for getting the diagnosis. Sure. There may be a conscious motivation to get the diagnosis because they become eligible for disability, whereas they might not get disability for some other diagnoses, like if it's methamphetamine addiction. And I'm not saying whether that's right or wrong, whether they should or shouldn't, but there is sometimes other incentives involved on the part of the patient. But no, I'm certainly wouldn't blame the patient for getting caught up in all of this.
Sure.
Yeah, but there are some, and I think that's obviously the minority of people, but there are some that do manipulate the system for that. So I think that is just, and I'm trying to cover all what I see as the different elements that may have gotten us here. And I think this is just a tiny one. I think there's some other ones that are more general ideas, or at least this one is very general, which is this idea that as a diagnosis is thought to be more common, then a doctor is more likely to diagnose it to keep up. So rare things are diagnosed rarely, but common things are diagnosed commonly. And so as many things in the system start putting more focus on mania, and it's on everybody's radar, and then suddenly people are identifying it in places where they wouldn't have identified it before. And we've talked about some of these factors. I mean, whether it's the drug companies, whether it's the patients asking about it, whether it's a market incentive. And then another thing is that sometimes diagnoses just get trendy. It's gotten more popular to have a diagnosis of bipolar, and whether that's due to some of the things we've already talked about or not, just like it was popular to have multiple personalities in the 1970s, which, by the way, is getting more popular again now, at least from kids on TikTok, where there's all these videos of how to go and pitch yourself as somebody having dissociative identity disorder.
Right.
And then something that I have wondered about is that, at least over the course of my career, there are many more people who are now in the diagnosis game, I would say. And I think that has to do with who insurance companies will reimburse for a diagnostic evaluation. And I'm not saying that one is better or worse, but what I do notice is that there are many people that make a diagnosis that in their training, they never had the opportunity to take care of people with mania, like actually see them and to have a frame of reference for what it looks like. And so it's really more of an abstract concept. And I think when it's left in the abstract, it's easier to push people into the idea or to be more comfortable with the idea of this notion of a spectrum.
Yeah, and I guess that's what I was trying to say earlier, that, a truly manic person is hard to miss, right? And just like you said, a lot of training programs aren't structured to provide that kind of exposure.
Yeah, which is really unfortunate. I wanted to talk about the impact, because once that label is there, even trying to undiagnose somebody, good luck telling the life insurance company or your medical record documentation. And again, there's a reason to try to be accurate, and I think sometimes we forget about that. I had one other idea about this trend, and I think sometimes people make up their own rules. We were just in a discussion just now about, well, should the criteria be different? And some people would argue for that. But one example that I see all the time is well, you came and you were depressed. I gave you a medicine. You didn't get better, so it must be bipolar depression. And I think, how much hubris must you have to think that, it has nothing to do with the fact that maybe the treatment just failed because it's not a very good treatment. And the idea of just, well, let's just give you more toxic drugs. I don't know. Have you seen anything like that?
Oh, yeah, absolutely. I mean, I think if we're following the rules, I think that's prudent to reassess your diagnosis if the treatment that you're offering doesn't work. But I mean, it's also fair to say that these medicines don't work all the time, but it's a syndrome, right? If you say, well, the medicine didn't work, it must be bipolar, is, I mean, you say hubris, but also perhaps lazy. Again, are we looking at substance abuse? Are we looking at personality? Do we know about their history? Is this something that needs to be worked out in psychotherapy? Maybe medicines aren't what this person needs for a variety of reasons. You can run into these ideas, but they're all syndromes, and all of the medicines can treat a piece of it. But I think you're right that these medicines can be toxic, many of them, and it's not benign just to throw another pill at a person, either from a medical standpoint, let alone a treatment standpoint, when you actually want someone to get better. If the bipolar medicines then don't make that person better, then what's the next diagnosis we're trying? Like, I don't know.
Yeah.
There's a lot in there, but.
Well, I was thinking about the idea of provisional diagnoses and how I don't want to come across as saying that the unspecified category should never be used, because I think it's actually really helpful sometimes because you don't have enough information. You need to get more data. You need more time to get the data. You need to see what's going to happen over time. And I think that's important. So I don't want to come across as being overly passionate about this. I just think that, back to Shelby's point, there are some actors that at least aren't being as thoughtful as we would like them to be.
I think that's well said.
Okay. Well, we mentioned a little bit about, so why do we need to try to be more faithful in a diagnosis? And I would say, well, the only reason to even have a diagnosis is so you understand what's the best treatment and to understand your prognosis, just to have some idea of what might happen. Also, I think this is going to have a negative impact on research, because if we can't agree on what the illness is and what it's not, well, that's really hard to study. I think, as we said before, I've definitely had to undiagnose people, and sometimes they're understandably relieved. I mean, if they no longer have this label of a chronic illness, it's going to require all these medications. But other times it's really hard to let go of being sick in that particular way. All right. Well, Shelby, I hope this helps. I have a feeling the trend is going to continue. I think we're going to keep casting an ever widening net. And as I said earlier, I think there's pros and cons to that.
I bet it'll continue. I also bet it'll fizzle out. I mean, do you see schizophrenia being overdiagnosed anymore these days? Too much?
No. I mean, again, kind of like with bipolar 1, I think the prevalence has been maintained.
Yeah. I'm not seeing housewives on Valium coming in anymore with a schizophrenic diagnosis. Those days are behind us.
There's a couple of diagnoses I can name that will probably usurp bipolar in popularity in terms of trend. I'm not going to say. No.
What? Offline?
I'm not going to.
I want some money. You won't?
Off mic, I'll tell you.
You are a different person than me, because anytime I can go on the record and be right, I would take that opportunity. But you're good for you. Dr. Hanley, way to go.
All right. So when we get back, we are going to answer a question about the therapeutic relationship. All right. So we are back. And this question comes from a listener who wanted to be identified by the initials FW. Why do therapists make it sound like the therapeutic relationship is this big, mysterious thing that's so critical? The reality is there is no relationship. It's a paid-for service, and that's pretty much it. Why make it out to be more than it is? I love this question.
I do too.
I love the
FW is
tone in
coming
it
in
too.
hot.
Yeah, I know, coming in
Uh-huh.
hot.
Yeah, yeah.
I love it.
So I'm going to try to break this up into two chunks. I mean, I think in its essence, right, when they are saying it's a paid service and that's it, points out that there is a transactional nature in a therapeutic or psychotherapeutic relationship. I think that probably is most evident in that the patient gives the therapist money in exchange for their time. I'm going to, go out on a limb here and say I don't think that that is in and of itself problematic or means that there isn't a relationship going on. I think the therapist definitely does and can care about their patient, even if there's a transactional element. I might even say that most relationships have a transactional element to an extent, and that maybe even some of that is helpful in establishing that there's a relationship, that there's a give and take, that, the patient comes needing help. They are getting the therapist's time and expertise, certainly, which maybe would be with any sort of service provider. But that the therapist also has needs in this, namely to make a living and provide for themselves. So anyway, I'm not that worried about the fact that there is some transactional nature to the relationship. I think that is okay. But I would also like to point out that the relationship is widely recognized as the most common factor to success, that there's studies, including a big meta-analysis by the American Psychological Association, that basically said that the therapy relationship is the most substantial and consistent contributor to psychotherapy outcomes, that was more important than the type of treatment or even the discipline of the therapist, and that the therapy relationship is, again, the biggest factor in why the patients or clients fail to improve or improve. And so I don't know. I think that's pretty powerful. Is that an idea that you've come across before?
Yeah, I think a lot of people understand that now, that if you don't have that alliance, the therapy is not going to be as successful. And that's really important. When I talk to people who are looking to find a therapist, I mean, I bring that up all the time. Like, you've got to make sure that there's some kind of affinity there, even hopefully early on, in order to get the most for your money, basically.
Yeah, I mean, I think that's right. I think that it's pretty hard to fake empathy. I think that if a patient is in a situation where they really believe that the therapist is uninterested in them or not paying attention or whatever form that takes, I can't imagine a way that that would be helpful. So, I mean, just at baseline, there has to be a consistent, positive piece of a relationship to keep things going.
I would hope that the patient feels cared for because they are in fact being cared for, right? That's not manufactured.
Yeah,
Um, and
right.
and I think that I mean, to say it's not a relationship, I don't really quite even understand what that means, but it may be different than other relationships. It might be free of judgment. It might feel
Hopefully
unconditional.
it's different.
Right. Because when there's ruptures, that you actively try to repair those things. I don't know if there's something about it because it's supposed to be so different, if that's why it feels like it must not be real.
The idea that this is just a service, it's like, well, what would the service be? Because I like therapy is not really something that's like done to you, right? I mean, it's a process, it's a relationship. I would say the service is the relationship, that the patient is, again, paying, is engaged with the therapist in a joint pursuit to have an experience with that therapist. That what I'm offering as a therapist is myself. I mean, it can be all the studying I've done, my knowledge, my practice in technique, but that's not enough. I have to get to know my patients individually and think about what they want and, well, what they want out of their life. Sometimes it's what they want from me, though, that could be different. I think, to your point, it's different than other people in our life, even people who care about us. It's different than friends or family or self-help books, right? I mean, therapy is not just advice or education or support or a place to vent. It can be all of those things, but all those things happen in a a specific relationship to another person. I keep trying to think of a different word, but I'm not sure that there is one.
Yeah, that reminds me. I think a lot of times when therapy's going well, a patient might try to give me some credit, and I think, they're actually doing all the work, right? There's so much that happens, not just in that hour, but they're the ones trying to put it all into place. I don't know if that's what feels foreign to the question asker or not. But anyway, what was resonating with me was you saying that therapy is not a passive process. It's not to be done to you. It's I hear that all the time. Like, you need to go get you some of that therapy. It's like, well,
right.
You actually have to arrive with a lot of
gotta get therapized.
Yeah, like you got to have some curiosity and interest and willingness to be uncomfortable. For things to maybe actually feel worse before they get better.
Oh, yeah, indeed. Yeah, no, it reminds me. So I went for jury duty. I was a resident, and they ask all these questions, and there was some either show of hands or something to say if your work would prohibit you from participating in this trial, which they expected to last 3 or 4 days. And so I indicated that was me, and I was maybe a little bit self-important, but they say, well, give your justification. And so I say, well, I'm a therapist and I have patients, including children. This is how I know as a resident. And they really need me to be there, and it could be disruptive to cancel their appointments. And the judge said to me, well, it's not like you're a surgeon or something. And I was like, yeah, because the surgeon's patients are asleep. I cannot be substituted for, which is both totally arrogant and self-important, but totally true. You can't just slot somebody in there. It's not how it works.
Wait, did you get out of jury duty? I know that's not your point.
I sure did.
You did?
I got out of
really?
jury duty. Yeah. I heard they never pick psychiatrists because we have too much empathy for all sides of a case. But I think,
that wouldn't be the reason I wouldn't be picked.
Well, okay, fine. Why wouldn't you be picked?
Oh, I don't know, but it wouldn't be excessive empathy on both sides.
I don't know. But I think one or the other of the attorneys decided maybe they just didn't want some mouthy broad on their jury. But
so you shirked your civic responsibility. Yeah. That's kind of the point of the story.
I sure did. I sure did, because the children at the youth.
The children needed you. Okay.
The children needed me. What was I supposed to do? Well, no, but to this point, right, where if it's a paid service, if I show up to my massage therapy appointment and they say, as they've done recently, your massage therapist is out because they have COVID, but we have a substitute for you, I might be mildly disappointed because I like the other person or like their technique, but I could get more or less the same service, which is great, not to undermine the massage therapist. But if you show up to your psychotherapy appointment and they say, oh, your doctor's out sick, we have a sub for you, it doesn't really work.
Right. Yeah. They read the last years of notes. They're kind of caught up.
Yeah, they know you. They got you. Right? It's so hard to get with. It's intimate. I don't know. We could talk about that forever. But I think when looking at this, it's a fee for service, to me, from my perspective, it falls apart pretty fast. Another thing I think about is, do you have patients who they might call themselves, I don't know if you would, medication only patients, like people that aren't in psychotherapy with you, quote unquote?
No, I don't use that term. It is true that they may not be in any kind of structured or long-term psychotherapy, but I would say that I would hope that all our interactions are therapeutic, or that they can be therapeutic. But I don't do this. I hear about people doing a 10-minute check or something, and I always think
how?
If we can accomplish what you need in 10 minutes, you probably didn't need to talk to me. Schedule next month or something. I don't quite understand that.
I don't either, but I definitely have had people inquire about medications only or ask for a pharmacotherapist. I kind of get where the concept comes from, but I think in practice, this is a little bit like our discussion of the bipolar stuff. If someone just says, comes in and gives thumbs up, thumbs down, or like better or worse, sleeping, eating, concentrating, I suppose that tells me a little bit, but I actually care about my patients and their symptoms, and I guess their medications, because I want their lives to be better. I don't know, if one of your symptoms is going up or down, like, okay, but does that allow you to function? Does that allow you to be the kind of parent or spouse or worker you want to be? Like it matters how these symptoms show up in context.
Right.
And
Yeah, I was going to say, out of context, it's all meaningless, right? Like, oh, I haven't been sleeping well. Okay, here's another pill. And it's, oh, because my spouse died last week, right? I mean, I
right,
know that sounds ridiculous,
right,
but yeah, context is important. That's why those checklists for diagnoses are often useless because they're acontextual.
right, right. You gotta dig into everything around that. And then even if a medication change is warranted, there's going to be different factors, including personality traits or other things, other sort of sensitivities that come into play. I feel like I can learn so much about someone by how they approach these kinds of interactions and how they approach the recommendations, especially when I'm paying attention to the relationship. So even if they think me as a glorified prescription pad, I still think we have a relationship.
Yeah, I mean, I wouldn't mind being a vending machine if the output was more effective, you know. I mean,
Right?
if I knew that it
Yeah.
was going to solve the
Yeah.
problem, and okay, here's your Valium, you know, if you put the coin in.
Right. I'm not taking extra time just because I don't even know why. I don't even know why somebody would, right? Don't most people want faster, cheaper, quicker results with less effort? I mean,
Yes.
I don't know. Welcome to being a human. Like we're doing it the best way we know how. I don't know. I mean, it sounds like you don't get a lot of this kind of pushback. I mean, have you had patients come to you with these kinds of concerns? I mean, to me, it's usually the other side of it of like, you know, alas, this is transactional, but I wish I could have more of you. But I don't know, what's happened for you. I mean, Dave, have you ever just thought of yourself as a highly trained prostitute? Does anybody try to tip you for a job well done? I do. I have this guy that tries to tip me like in cash frequently. And I mean, again, my waitressing days are behind me. My prostitution days are in front of me. I don't know.
I have a
I don't
strict
know what to
policy. Well, I
say.
have a strict policy. You can't make it rain in my office, so
You can't.
you
I
can't.
mean, do
No.
you ever get a big wad of cash though?
I've gotten people try to pass me cash as a tip. I don't accept those, of course. Some people, it's just an expression of thanks, but that gets into gift giving, which I think we covered in another episode. But
We have
um,
covered that. But yeah, no, I am truly curious what you think about the prostitution comparison.
yeah, I've had patients ask that, and usually my quip is always, "Yeah, but I have a lot more paperwork I have to do." um,
Right?
but when it has come up, then I mean, it tells me that I need to work on the alliance. I need to
Yeah.
understand more of what's going on. So, and I think to tie this back to FW's question, um, I, I guess I'm sorry that that person hasn't experienced the relationship we're
Oh
talking
yeah.
about, and I think that the fact that it's not happened is just information that you need to discuss with your therapist, to find out what the
That's right.
barriers are. Maybe it's not a good fit, or you know, is there something to that? I just think there's something could be very useful in understanding why that connection isn't there. And if you don't like the person, I
Yeah,
mean, that's okay too. And maybe that would go back to,
of course.
not to keep referring to old episodes, but breaking up with your psychiatrist. And actually, I will refer to old episodes because I think this has come up. This has been a through line through many episodes. You know, you always say it's a real relationship. Before you say anything, you always say because it's a real
Hmm.
relationship.
I mean, I just believe it, right? And you're right in terms of what's behind this. I have no idea for the question asker, but again, is it about the therapist not caring? Is this some sort of protection against grief? Because I think not uncommonly, it is sad and something to be grieved that the therapist has human limits. The therapist isn't always there or isn't always going to provide an idealized form of care. As much as a therapist might try to, their life or might interfere, and they're going to make mistakes. And so I could almost see it as being productive, as treating it like a purely transactional service that only exists in the hour. But, as we've been talking about, it just goes a lot further than that. And I mean, yeah. The prostitution, you fill out more paperwork, right? I actually think in contrast, we get paid to not have sex with our patients. And in terms of like the service, if you're not getting a relationship, I don't know what you're getting. Like, people, unfortunately, I'm not saying I like this, but you might feel worse at the end of a session when you're working on something. It doesn't always feel good, but it's going to be about growth. I don't know, but I don't, it's probably has to do with being a woman. Maybe people are less likely to overtly compare me to a prostitute, though it's like not a good feeling when somebody tries to give me a cash tip at the end.
They're just saying things. You used to say that, and this is probably more in analytic or dynamic therapy, but somebody needed to be uncomfortable by the end of a session, whether it was the therapist or the patient. So back to your point, that's
how you know something's happening.
Yeah, something's actually happening, and growth will come from that. So I don't know if that's as you're saying, I don't know if that's a part of this question asker's experience or not. That it's just been really uncomfortable, or if there's just not a lot of feelings of care there. So I hope this was
too much or too little of something. Right? I don't know.
Well, I hope this was helpful. I tried to email FW to see if that person wanted a sticker as a token of our gratitude, but the email didn't work. So if this listener's out there, please let us know. I'm happy to send you one if you'd like it. So,
or anyone who wants a sticker, we are more than happy to send you a sticker. How can they do it, Dave? Let us know. They can ask a question. They can join the Facebook group. They can sign up for our newsletter on our website.
I think you got it.
What else? Is that what they can do? You can call us. I mean, there's multiple ways to ask a question, but we need them, folks. If we're not interesting to you, ask your own question about what you're interested in. That's how you get the episode you want.
Yeah, regardless of the incentive, we really would like to hear from you guys, and you can contact us at callthepsychiatrist.com. And then some other requests, if you could tell a couple of friends about the show. And if someone out there would just write a review on the podcast app they're using, we would love that. Also connect with us on Instagram or Facebook. Those accounts are at Call the Psychiatrist. And as Abby mentioned, there's a page, but there's also a private group on Facebook. So take care.
Goodbye. Yeah. No, I was going to say, now that we've really established that we're not prostitutes, if you write the first review, then you name your reward and we'll see if we can come through. Now that we got all that out of the way.
Yeah, now that we've taken that off the table. So.
That's right. We have limits. Haven't we been really clear about our limits?